The topic for discussion is acute gingival infections. So in this we will learn about three conditions. Those are the necrotizing ulcerative gingivitis, primary herpetic gingivostomatitis and pericoronitis. So this necrotizing ulcerative gingivitis is a microbial disease of the gingiva that will occur in impaired host. So when there is impaired host response, usually this disease is seen, and it is characterized by some clinical features like necrosis and sloughing of the gingival tissues, and this may be accompanied by systemic symptoms also. So a very important clinical feature is necrosis. So whenever you're given MCQ questions also, necrosis and sloughing of the gingival tissues will be mentioned. So these are the characteristic features by which you can give a diagnosis of necrotizing ulcerative gingivitis. So the other oral signs include punched out crater-like depression which are present at the crest of the interdental papilla, and these may extend into the marginal gingiva also. So these punched out crater-like lesions are seen in the interdental papilla, may extend into the marginal gingiva, but they are not seen in the attached gingiva and in the oral mucosa. There will be a gray pseudomembranous slough. So this pseudomembranous slough is demarcated from the remaining gingival mucosa by a linear gingival erythema. So in some cases there won't be any pseudomembrane. In such cases, since the pseudomembrane is not there, your gingival margin is exposed. So this gingival margin is red, shiny and hemorrhagic. There will be spontaneous gingival hemorrhage or pronounced bleeding even after the slightest stimulation. These are the additional characteristic clinical signs. So here in the picture you can see the typical punched out papilla in between the mandibular, canine and the lateral incisor in the first picture. In the second picture, this is a more advanced case showing the destruction of the papilla resulting in irregular marginal contour in the anterior region in between the central incisors. Next, in the C picture you can see the typical lesions with the hemorrhage. In the last picture, you can see the generalized involvement of the papilla and the marginal gingiva. Next, we will learn about the oral symptoms that are seen in the necrotizing ulcerative gingivitis. So, these lesions are extremely sensitive to touch, and patient often complains of constant radiating and gnawing type of pain that is intensified by eating spicy or hot foods and chewing. There is metallic foul taste, and patient is always conscious of an excessive amount of pasty saliva. Always remember these oral signs and symptoms. This will give you the diagnosis. So whenever you're asked case-based questions, all these terms will be mentioned. Punched out crater-like lesions, pseudomembranous slough, this metallic foul taste, pasty saliva, radiating pain. All these terms will be mentioned in your case-based questions in order to help you with the diagnosis. Next, we will see the extraoral and systemic signs and symptoms. In mild to moderate cases, the patients are usually ambulatory and have minimum of systemic symptoms. Local lymphadenopathy and slight elevation in temperature are the common features that are usually seen in mild and moderate stages of the disease. But in severe cases, there will be high fever, increased pulse rate, leukocytosis, loss of appetite, and general lassitude. So these systemic reactions are more common in children, and there might be constipation, gastrointestinal disorders, and sometimes headache and mental depression are also seen. In very rare cases, gangrenous stomatitis also has been described. Gangrenous stomatitis and noma has also been described. Next, we will see about the histopathology of this lesion. It is usually non-specific, involving both the epithelium and the connective tissue. We have seen that there is a pseudomembrane formation. So, the epithelium is destroyed, and this destroyed epithelium is replaced by a meshwork of fibrin, necrotic epithelial cells, different kinds of microorganisms and PMNs. We have seen that there is a demarcation in between the pseudomembrane and the normal epithelium by a linear gingival erythema. Okay, so at the immediate border of this necrotic pseudomembrane, the epithelium is edematous, and there will be different cells exhibiting the hydropic degeneration. So the connective tissue has lot of capillaries, engorged capillaries, and there is dense infiltration of PMNs. So this acutely inflamed zone is the one that is clinically appearing as linear erythema beneath the surface. Next, we are seeing a bacterial smear from the lesion in necrotizing ulcerative gingivitis, wherein you can see different kinds of microorganisms. Remember these microorganisms, those are the spirochetes, Bacillus fusiformis, filamentous microorganisms like Actinomyces or Leptotrachea, Streptococcus, Vibrio, and Treponema microdentium. Next, we will see the etiology of necrotizing ulcerative gingivitis. So, the bacteria are responsible, impaired host response is also another factor, local predisposing factors are there, systemic predisposing factors in which we have the nutritional deficiency, any debilitating disease, and psychosomatic factors. So, different researchers have told that there are certain bacteria that are responsible for the necrotizing ulcerative gingivitis. So, it was stated that fusospirochetal complex consisting of Treponema microdentium or another type of flora like Prevotella intermedia, Fusobacterium, Selenomona species, these particular species are responsible for the development of the necrotizing ulcerative gingivitis. Coming to the host response, regardless of whether the bacteria are specifically seen in the etiology of necrotizing ulcerative gingivitis, there is a sufficient evidence to state that these bacteria alone are insufficient to cause the disease. So, there must be an impaired host response. In such cases, the necrotizing ulcerative gingivitis will be developing. So, this necrotizing ulcerative gingivitis was seen in patients who are suffering from physical as well as the emotional stress, and these people will have the decreased resistance to infection. Therefore, host response is the main factor in the development of necrotizing ulcerative gingivitis. The local predisposing factors include smoking, pre-existing gingivitis, or injury to the gingiva. Coming to the systemic predisposing factors, we have the nutritional deficiency, wherein a poor diet has been suggested as the factor that is responsible for this infection. Nutritional deficiencies like vitamin C, vitamin B2, they accentuate the severity of the pathologic changes that are seen. Next, debilitating diseases include chronic diseases like syphilis, cancer, severe gastrointestinal disorders, acquired immunodeficiency syndrome. And psychological factors also play an important role in the etiology of necrotizing ulcerative gingivitis. So, this disease often occurs in stressful situations like induction into the armed forces or in school examinations. Psychological disturbances, increased adrenocortical secretion are more common in patients with this disease. Next, we will learn about the second condition, that is the primary herpetic gingivostomatitis. So, it's an infection of the oral cavity that is caused by HSV1, herpes simplex virus type 1. It is most common in infants and children who are younger than 6 years of age. It is also seen in adolescents and adults, but it is more common in children who are younger than 6 years of age. So, it occurs equally in both males and females, and in most persons, the primary infection is asymptomatic. So here in the pictures you can see the recurrent herpetic vesicles in the lip. So A represents the early stage, whereas B represents the late stage, showing brownish crusted lesions. So these are also the characteristic features that you have to remember in order to know the diagnosis of the condition. So the next picture you can see the first picture in the slide, you can see the recurrent oral herpetic vesicles on the palate. So in the next picture you can see the intraoral herpetic vesicles on the gingiva, which is however very rare location, and in the last picture you can see the erythematous involvement of the gingiva and also gray vesicles on the lip. Next you can see the involvement of the lip, gingiva and tongue, and also aphthous ulcers are seen on the lip. So this per primary herpetic gingivostomatitis lesion is accompanied by generalized soreness of the oral cavity, because of which there is interference in eating, drinking, and also performing oral hygiene. So these ruptured vesicles, what you have seen in the pictures, these are the main sites wherein the patient will be complaining of pain. These are the focal sites of pain, and they are particularly sensitive to touch, thermal changes, and also foods such as fruit juices, and also because of the action of coarse foods. And these patients will also have systemic signs and symptoms such as fever as high as 101 to 105 degrees Fahrenheit. Next, we will see the histopathology of this lesion. So here in the picture is a biopsy which shows the intraepithelial viral vesicles. So these are containing fluid and debris with large number of viruses and also altered epithelial cells, which are called as Zank cells. So this table helps us in differentiating between the necrotizing ulcerative gingivitis and primary herpetic gingivostomatitis. So NUG, necrotizing ulcerative gingivitis, is caused by interaction in between the host and bacteria, and mostly the bacteria involved are the fusospirochetes, whereas the primary herpetic gingivostomatitis is caused by viral infection, that is by HSV type 1. So necrotizing ulcerative gingivitis is a necrotizing condition, whereas in primary herpetic gingivostomatitis there is diffuse erythema and vesicular eruptions are most common. NUG has punched out gingival margin, pseudomembrane is present, that is peels off. Once the pseudomembrane is not present, the gingival margin is shiny, red and hemorrhagic. Whereas in PHG, the vesicles that rupture leave a slightly depressed oval or a spherical ulcer. Marginal gingiva is affected, so mainly interdental papilla is affected, which may extend into the marginal gingiva, whereas the attached gingiva and the oral mucosa are rarely affected, whereas in primary herpetic gingivostomatitis there is diffuse involvement of the gingiva. It may even include the buccal mucosa and lips. Very important point, it's uncommon in children in case of necrotizing ulcerative gingivitis, whereas primary herpetic gingivostomatitis occurs more frequently in infants and children who are younger than 6 years of age. There is no definite duration in necrotizing ulcerative gingivitis, whereas the duration is of 7 to 10 days in PHG. No demonstrated immunity in NUG, whereas in PHG the acute episode results in some degree of immunity. And the contagion is not demonstrated in NUG, whereas the contagion has been demonstrated in case of primary herpetic gingivostomatitis. The third condition in this acute gingival infections is the pericoronitis. So this pericoronitis is the inflammation seen on the pericoronal flap. So it's inflammation of the gingiva in relation to the crown of an incompletely erupted tooth. So it is most often seen in the mandibular third molar area. So this pericoronitis can be acute, subacute or chronic. So the partially erupted or the impacted mandibular third molar is the most common site of pericoronitis. The space in between the crown of the tooth and the overlying gingival flap is the ideal site for the accumulation of the food debris and the bacterial growth. So this overlying gingival flap on the crown of the tooth is called as operculum. Excision of this operculum is called as operculectomy. So in the treatment of pericoronitis, in some cases you will excise this flap. Okay, excise this operculum, which is called as operculectomy. It is performed when you decide to retain the tooth. In such cases, you will be performing operculectomy. In some cases, you will be deciding to extract the tooth. It will depend on several factors. Next, we will see about the treatment of these acute gingival infections. In the first one, we will see the treatment of necrotizing ulcerative gingivitis. So when the patient comes, the first visit you need to perform the comprehensive evaluation of the patient. You need to take thorough medical history, any recent illness, living conditions, any change in the dietary background, cigarette smoking, type of employment, hours of rest that the patient is getting, risk factors for human immunodeficiency virus infection, any psychosocial parameters, that is stress and depression. See, all these factors are involved in the etiology of necrotizing ulcerative gingivitis. So you will take a thorough history regarding all the etiologic factors that are associated with necrotizing ulcerative gingivitis. So these are the evaluations that are performed in the first visit. Remember that in the first visit, the goal is to reduce the microbial load and the goal is to remove the necrotic tissue. So if you remove the necrotic tissue, it will facilitate the healing process of repair and regeneration. So the goal of the initial therapy is to reduce the microbial load and remove the necrotic tissue. So during this first visit, you will actually isolate the areas with cotton rolls and you will dry the area. Afterwards, a topical anesthetic is applied and after 2 to 3 minutes, the areas are swabbed with a moistened cotton pellet so that the pseudomembrane is removed and the non-attached surface debris which is present is removed with the help of cotton pellet which is moist. Okay, so when performing this, the bleeding may be profuse. Okay, so each cotton pellet you have to use it in a small area and you need to discard it and then take another cotton pellet, moistened cotton pellet, and you need to continue the procedure. So With a single cotton pellet, you should not perform the sweeping motions over the large areas. Then you need to cleanse the area with warm water, and the superficial calculus is removed. In removing the calculus, you can use the ultrasonic scalers, which will be very useful because they do not elicit any pain, and there will be water jet, so there will be lavage of the area. So in such cases, ultrasonic scalers are particularly very useful. In this visit, you should not perform the subgingival scaling and curettage because these procedures will extend the infection, so they will cause bacteremia. So you should not perform the subgingival scaling and curettage at this time. And unless an emergency exists, procedures such as extractions or periodontal surgery are postponed until the patient has been symptom free for 4 weeks. This is because you minimize the exacerbation of the acute symptoms. So that's why you will not perform these extractions or the periodontal surgery, and in order to prevent the bacteremia, you will not perform the subgingival scaling and curettage. And patients with moderate to severe necrotizing ulcerative gingivitis will benefit from antibiotics. So the antibiotics used in this cases are amoxicillin 500 mg orally every 6 hours for 10 days, and in patients who are sensitive to amoxicillin, erythromycin or metronidazole can be used. So if there are any systemic complications, then only you will be using this antibiotics. Antibiotics are not recommended in NUG patients who do not have any systemic complications. Next, we give instructions to the patient. We tell the patient to avoid tobacco, alcohol and condiments. The patient is told to rinse with an equal mixture of 3% hydrogen peroxide and warm water for every 2 hours, or the patient may be advised to use chlorhexidine 0.12% twice daily. Patient is told to get adequate rest. Patient can perform usual activities, but he should avoid physical exertion or prolonged exposure to sun. The toothbrushing has to be confined to the areas only for the removal of the surface debris, and with the help of an ultra soft toothbrush, the oral hygiene procedures have to be performed. Overzealous brushing has to be avoided. So analgesic, that is NSAID, for example ibuprofen, is given for pain relief, and patients who are having systemic complications are given antibiotics. And in case of systemic complications like high fever, anorexia and malaise, the patients are given antibiotics, and patients are told that the bed rest is necessary, and there should be copious fluid consumption, and administration of analgesics should be done for the relief of pain. Next, in the second visit, which takes place approximately 1 or 2 days after the first visit, the patient is evaluated if there is any decrease in the signs and symptoms. So usually at this visit, the patient's condition is usually improved, and the gingival margins are erythematous without a pseudomembrane. So in this visit, you can perform scaling, and if patient can bear the sensitivity, then you can perform the scaling. Since you have already performed the scaling in the first visit, there will be some amount of shrinkage in the gingiva, so there will be previously covered calculus will be exposed at this stage. So you need to remove this calculus. You can perform superficial scaling if necessary, and if patient can bear the sensitivity. Okay, so the instructions which were given in the first visit are again given in the third visit, which takes place approximately 5 days after the second visit. We need to check if the symptoms have resolved or not. Then a proper plan for the management of the patient's periodontal condition has to be formulated. A very important point is that hydrogen peroxide rinses are discontinued, and oral hygiene can be maintained for 2 or 3 weeks using chlorhexidine rinses, but hydrogen peroxide rinses are discontinued. You can repeat the scaling and root planing if necessary. And remember, the patient should be counseled about the nutrition, smoking cessation and other conditions and habits which are associated with the recurrence of the condition. Patients should be told that the recurrence rate is present, so you need to avoid this condition. So patients should be counseled properly. Next, we will see the treatment of primary herpetic gingivostomatitis. The treatment consists of early diagnosis and immediate initiation of antiviral therapy. So, until recently, the therapy for this condition was only the palliative care. So, if the diagnosis is made within 3 days of onset, then you can give the acyclovir suspension. If the diagnosis has taken place after 3 days of onset, then palliative care such as removal of the biofilm and food debris has to be done. In order to reduce the fever and pain, NSAIDs can be given. So patients can either use the nutritional supplements or topical anesthetics can be used in order to aid in the eating. So before eating, we can use the topical anesthetic so that proper nutrition can be provided in the early stages of this disease. So if the condition does not resolve within 2 weeks, then you need to refer the patient to the physician. Next, we will learn about the treatment of pericornitis. This treatment depends on severity of inflammation, systemic complications, and whether you're planning to retain the tooth or extract the tooth. So this treatment consists of gently flushing the area with warm water in order to remove the debris and the exudate. You lift the pericorneal flap with an instrument and gently swab with the antiseptic. Occlusion is also evaluated. And in the picture, you can see the procedure of operculectomy wherein the pericorneal flap has been excised. So this is done once you have planned to retain the tooth. Now we come to the conclusion of the topic. The acute gingival diseases are similar as they manifest with painful intraoral and perioral lesions, and since they are painful, they need urgent treatment in order to relieve the symptoms. So each case has specific characteristic signs and you need to be thorough with the diagnosis and also the differential diagnosis and identification of the risk factors. In many cases, there are systemic risk factors that will increase the susceptibility to the acute gingival disease. So in this topic, that is the acute gingival infections, we have learned about 3 conditions, that is a necrotizing ulcerative gingivitis, primary herpetic gingivostomatitis and pericornitis. The important questions from this topic include the clinical features of necrotizing ulcerative gingivitis and the treatment of this condition. You need to be thorough with the treatment procedures that can be performed in first, second and third visit. What are all the mouthwashes that are used in each visit? And you need to be thorough with the characteristic clinical features of each acute gingival infection. So this topic is an important source of MCQ, especially case-based questions can be asked from this topic. Thank you everyone for your patient listening and all the best.